Radium-223 therapy indications, case discussions. Speaker, Dr. Vidrinskaitė, radiation oncologist from National Cancer Institute. Please, doctor.
Hello, I'm Asta Vidrinskaitė, radiation oncologist. I'm working at the nuclear medicine department, and I'm working with the treatment of patients with radium-223. Radium-223 has a dual mode of action. It induces potentially cytotoxic DNA double-strand breaks in adjacent tumor cells, osteoclasts, and disease-promoting osteoblasts. Also disrupts the cycle between tumor cells and bone microenvironment. In a large phase 3 ALSYMCA trial, more than 900 patients with symptomatic metastatic castration-resistant prostate cancer who failed or were unfit for docetaxel were randomized to 6 injections of radium or placebo plus standard of care. The primary endpoint was overall survival, and radium-223 significantly improved overall survival by 3.6 months. Radium-223 was also associated with prolonged time to first skeletal event by 5.8 months. What's to be noted that in radium-223 arm, pathologic fractures happened to 4% of patients, while in placebo arm it was 5%. Basically there was no difference in both arms. All main secondary efficacy points, such as median time to increase in total ALP level, total ALP response, and total ALP normalization, also provided support for the benefit of radium-223 over placebo. Also, improvement in pain scores and in quality of life were noticed, and associated toxicity was mild and did not differ significantly from that in placebo arm. Since radium-223 is only bone-targeting agent, treatment combination trials were started, and now we have ERA-223 results and some insights of PEACE-3 trial, and DORA trial is underway. And the result from ERA-223 study was disappointing, and it was stopped early because overall survival in combination arm was significantly worse than in placebo plus abiraterone arm. Death rate in radium-223 arm was almost 35% compared to 27% in placebo arm, and also fracture rate was almost 3 times higher in radium-223 arm than in abiraterone arm. The higher fracture rate also correlated with higher death rate in radium-223 arm, and death without any prior fractures were practically identical in both arms. What was noticed that almost half of fractures in patients with less than 6 metastases, and almost 80% occurred at the skeletal site with no prior bone metastasis. What else was noticed in ERA-223 was that bone health agents dramatically reduced the risk of fractures and other skeletal events in radium-223 arm, which was also similarly noticed in early PEACE-3 trial results with enzalutamide. But what needed to be mentioned is that the PEACE-3 trial was modified after ERA-223 data of high fracture incidence was announced. As you can see in the table, the fracture rate without bone protecting agents was much more higher than in the arm with bone protecting agents, like 3% versus 37%. In treatment guidelines, radium-223 is more recommended as second-line treatment after docetaxel and at least one androgen receptors targeted agent, but is optional for first-line treatment if other treatment options is not possible. And well, basically the indications are metastatic castration-resistant prostate cancer with bone metastasis and no visceral metastasis when there are symptoms, and elevated biomarkers after at least one line therapy. In Lithuania, we have this indication that we need to use radium-223 only after at least 2 prior lines of systemic therapy for metastatic castration-resistant prostate cancer. And this treatment is possible in National Cancer Institute since 2015. And up until 2020, average treatment doses per person were 5.5. Out of 6, and only a few patients in the last 2 years received less than 5 doses of radium, and the reasons were death, visceral progression, and worsening of health status. There are 2 trials that National Cancer Institute participates in, and one is a phase 4 trial for metastatic castration-resistant prostate cancer, radium-223 versus new anti-hormonal therapy, and also phase 1 biodistribution study, a study to assess how radium-223 distributes in the body of patients with prostate cancer which spread to the bones. I would like to present a case report which we had last year. And the patient in 2006, 62 years old patient, was diagnosed with prostate cancer, CT3 and 0, stage 3. PSA was 33 and Gleason score was 6. No metastases were reported in the diagnostics, and patient was treatment was started with hormone therapy. PSA levels dropped to 1.35, and then radiotherapy was recommended, and the patient received radiotherapy to prostate up to 72 Gray and to seminal vesicles up to 50 Gray. But after the radiotherapy, patient's next visit was only after 7 years because of worsening health status, with symptoms such as back pain lasting for 2 weeks, difficult walking, ataxia, and progressive paraparesis. At that time, in CT scan, bone metastases were diagnosed, and mostly in spine and pelvic bones. PSA was 168. Thoracal MRI showed metastasis with spine cord compression at the thoracal 7 vertebral level. And this patient was sent to neurosurgery department and thoracal 7 laminectomy, and the compression was done, and histology showed prostate cancer metastasis. At that time, MDT recommended to renew hormone therapy and also to add zoledronic acid. PSA levels dropped from 168 to 0.15 at 2015, and the patient once again did a break with visiting his oncologist. And this last visit was in 2015. He showed up after more than a year, and at that time PSA level was 17.41, and castration was recommended, but the patient refused. So MDT decided on combined androgen blockade, and PSA levels as well dropped until 0.39 and started to increase slowly. At 2018, MRI was done because of increasing PSA level, but no obvious progression was noticed. It also showed multiple osteoblastic metastases in bones. And the patient continued hormone therapy until 2020, when PSA level increased to 12. And at that time, bone scan showed multiple metastases, more than 15 metastases, and it showed progression. ECOG was 1, and MDT decision was to start abiraterone treatment. At the start of abiraterone treatment, PSA was 24.52, testosterone 0.458. And during all the treatment, abiraterone treatment, PSA levels increased. And after half a year, bone scan showed that there are several new lesions, though some lesions were reduced in activity and some lesions were increased in activity. So MDT decided that due to progression, chemotherapy should be started. But because of concomitant cardiological problem, the patient was sent to cardiologist before chemotherapy. And once again, the patient came late, and that was like a 4-month break since the last visit to chemotherapist. And because of that, well, basically, most likely it was because of COVID restrictions. And after 4 months, we repeated CT scan and bone scan showed progression. And this time, since there was a serious cardiologic pathology concomitant with prostate cancer, MDT decided to start treatment with Radium-223, and PSA level at that time was 61. There you can see PSA level dynamics during all the treatment, and there are like 2 serious breaks of more than a year, 2016 and 27. This patient received all 6 doses of radium, and the total dose was almost 23 megabecquerel. Before treatment, the pain scale showed 3-4 points of pain. PSA level was 61, ALP was increased to 700, LDH was also increased to almost 400. After the 6 doses of radium, patient said that he feels no pain anymore. PSA level dropped to 8.3, ELP level normalized, LDH level also normalized. And bone scans showed that there are still multiple bone metastases, but compared to before treatment scan, effect was positive. And there you can see the dynamics in bone scan. The ones that are left are before treatment, and the ones that are on the right are after treatment. And you can see quite obvious the decrease in intensity of metastasis, and some of the small metastases are not seen. And until this patient continues hormone therapy, it's almost half a year after the treatment of Radium-223, and PSA levels stay stable. Thank you for your attention.
Thank you very much for your lecture.